have the pleasure to get to introduce our keynote speaker. So our keynote speaker today has 40 years experience in this space, both actually doing direct services and then on the state side and now working as a consultant. Throughout her career, she actually grew to be the Assistant Director of Clinical Services for North Carolina, and then the Assistant Director of Medicaid for North Carolina, and then the Acting Interim Director for Medicaid for North Carolina. As you can see behind me, she's now the Acting President of CCR Consulting, and she has a wealth of experience. Please give a warm Echo Vantage welcome for Tara Larson.
So good morning, everybody, and as we say from my home state, hi, y'all. I'm excited to be here this morning. I think what Matt just basically told you is I'm old and had a hard time keeping a job because I kept moving around. Stayed with state government, retired from state government, and my boss, the Secretary of Health and Human Services, said, come on, Tara, come do a little consulting. And I said, no, I want to play golf, I want to sail, you know, I've served my time. And so he said, no, help me out a little bit. So I did. Now I tell him, you just flat out lied. It wasn't part-time, and it's definitely, I haven't been sailing, and I haven't played golf like I want to do. But it's good to be here. What I'm going to talk about today, this morning, is really give you a kind of a different perspective of the beauty and the sting of technology. You know, lots of times when I talk and consult over the country, it's about convincing still in today's market the need for having an electronic health record. That's especially true in the behavioral health and IDD space. And so what I'm going to talk to you today about is why, as a payor, from a payor's perspective, you gotta have one. You gotta have one, or you won't be that preferred provider, and you won't be able to meet the demands of Medicaid, Medicare, and the commercial payer. And we all know that in the BH space, they are your payers. They are your payers. So we're going to talk some today about how things are changing in the health and human services field. Think about policy. Some of you I've known for quite some time. You've been in the system and you've known the system to be, first of all, there were block grants, as talked about yesterday. Then there was fee for service, and now there is managed care. Every single Medicaid program in the country, all 54 Medicaid programs. Wait a minute, 54? There's only 50 states. How can there be 54 Medicaid programs? District of Columbia, Puerto Rico, and the U.S. territories all have their separate Medicaid programs. And if there's one thing you know about Medicaid, if you've seen one Medicaid program, you've seen one Medicaid program. The other thing you know about Medicaid is there is one single answer to Medicaid. It depends. It depends. Because depending on how you ask the question, I can get you a no, or I can get you a yes. And the beauty about managed care is it provides you the opportunity to do things in the behavioral health space that you have never been able to do under fee-for-service. And we're going to talk about how some of those policies allow you to do things. We're also going to talk to you a little bit about today about why the funding is so interesting. Because you're going to get into the Medicaid space and the Medicare space. What's the difference between Medicaid and Medicare? Medicaid's indigent, Medicare is old. Medicare is federally managed and federally operated. Medicaid is federally regulated, state operated, and state managed. The feds will give you outliers on what each state has to do. And it's up to each state. So when I'm talking about what managed care looks like in North Carolina, or what managed care looks like in Ohio or in Illinois, the parameters are going to be similar. But how the state wrote that waiver, wrote that state plan, is going to make the difference of what you can do and can't do in your particular state. We also know the competition is great, the market share. We've seen small providers having to merge because of the infrastructure that are required. You had Chris yesterday, one of my colleagues, present about CIN, the Clinically Integrated Network. The CIN is a Medicaid, Medicare allowable regulatory that gives providers the ability to go together, to work together without actually being merged. So there are requirements and activities, but that's one way that many BEH providers are actually, it's been in the medical world for a long time. Another piece that I've got to emphasize in your space and in the Medicaid space is the issues of diversity, inclusion, and equity. You will see every Medicaid program in every state doing things to concentrate on this, including funding exceptional programs, innovative programs that actually address DEI. And that is not just about your EHR being able to say that we serve 32 people of African American and 80 people with this. It's about what are you doing with your programs and your services that actually reach out and make a difference to those people. So CBT with Native Americans needs to look differently than the way you present CBT to a Latinx community. And that's more than just being able to speak Spanish. All right? So the EHR also has to reflect that. The other point about health and human services is the idea that you are part of a bigger system. You are no longer the little the BH program over in the side. When I was at Medicaid as the director, served about 2 million people of a state of about 9 million. A $15 billion budget. Billion. We were the biggest budget in state government. The biggest budget. Everybody else's programs suffered or either benefited. Because if my program, I say my, because at that particular time, the deal was to try to grow the Medicaid program and maximize federal funding. Depending on what state you are in, some states are going to be very conservative and are only going to do what the federal government requires them to do, and that's called mandatory services and mandatory eligibility. In a state like mine, we did every mandatory and optional service that could possibly be until the administration changed, and we can't even get Medicaid expansion passed. Okay? There are 12 states that haven't passed Medicaid expansion. Child welfare and corrections. BH programs are a big part of those two systems. If you are not aware of FFPSA, Family First Prevention and something Act, that is going to be a big part of what your services and the Medicaid and the funders are going to expect. We also know that you've got to have data. You've got to have data. You've got to have data. The data's got to be replicable, and the data has got to be shared. There was not a provider who ever came into my office that didn't want a rate increase. We used to make jokes. Well, wonder how long it's going to take them to ask for a rate increase. That was only 30 seconds. Okay. Right? And then we turned the voice, we turned the message around. I'll give you a rate increase. I'll give you a rate increase. What's the outcome going to be? What's the outcome going to be? Not about how many people you served, not about how many units of service. I got that. I can look at paid claims. I can look at denied claims. But what is it that you're providing that is making a difference in that person's life? Okay? So you've got to be able to prove it. Not going to take your word for it. Every provider that I dealt with program integrity that I put in jail, literally put in jail, were quality providers according to them. All right? I had a conversation yesterday in your presentation about audits, not wanting to have paybacks. I thought, I can tell you how the Medicaid program actually does all these algorithms, and they have all these databases and software to actually point out, decide who gets audited and who doesn't. All about technology. That's a sting. That's a sting. So let's talk about how we get there. How we get there. You in this agency, where do we focus? How are we doing? How do we change? And what should we be doing? I've heard yesterday and looking at today's, you're going to be talking a lot about that. And then it all comes down to how we get paid. How are we financially compensated? But before we get to the compensation, you've got to look at your best practices. You've got to look at your analytics. You've got to look at your outcomes. We're going to talk a little bit this morning about how that is and how we go about doing that. How many of you would consider yourself part of the C-suite? I see a few hands. So most of you are middle managers or implementers or those kind of subject matter experts. Lots of agencies are still in hesitancy about their comfort with technology, just the whole use of technology. Even I brought a hard copy of my PowerPoint this morning. I printed it out before I got on the airplane. Because what if it doesn't work? What's my business plan? What's my contingency? Another issue that's facing providers is the ability or the thinking that they've got to have it perfect. They've got to have it perfect before they implement. Don't let perfection get in your way. I worked with a group of providers, even today, but when I was at the state, I had a group of 5 providers come in to talk to me. A group together, and they said, you're just not paying us enough for therapeutic foster care. You're not paying us enough for crisis services. And I said, all right. Pulled up the data. Wow. Your kids are using the emergency room an awful lot of times. Well, but they blah, blah, blah. I said, I tell you what. These are my non-negotiables. I want stable placements. I don't want the use of the emergency room unless somebody falls and breaks their leg, or they really have a medical emergency, not a sore throat, and not because the home can't handle them. I want respite services to give those foster families some relief. And I want an evidence-based practice in your model. You can choose what practice. And then you go back, you tell me what it's going to cost to implement it. And by the way, I'm going to have an outside evaluator look at your outcomes and your data. 10 years later, That practice is an EBP and just got added to the California Clearinghouse because of an innovation that came from you and came from the and from those. So make sure that you have the ability and you're willing to take the chance. You're willing to take the chance. And if you haven't seen Open Minds, I'm sure most of you belong to Open Minds. There was a great article just last August 20th. That can't be right. Today's the 20th. It was just last week. It must have been the 12th. On digital mindset that basically said 30%. When you guys were talking yesterday about the 30% rule, you're going to have the early adopters. You're going to have those who are going to say, no, we're not going to go. And from a payer perspective, those who surface to the top are going to be the ones that your payers are going to use. The payers are going to pick and choose because they have the ability to do that. They have the ability to do that. I love this cartoon rather. In general, I don't believe in a child labor, but sometimes they're the only ones who can figure out what's wrong with my computer. Be quiet, Chris. Chris is all my help one does. I can't get this computer to do what it needs to do. Press the button, Tara. I bring that up because when you're dealing with something like an EHR and being able to be innovative and put things on the table and looking at your data, sometimes it's the people who aren't the subject matter experts who can bring the stuff to the table. Sometimes it's the people that aren't even the clinicians who bring it up. Sometimes it's that 12-year-old kid who just came on 3 weeks ago who's looking at it differently. I work with two health plans. They have a think tank up in a state, and it literally is a huge, massive think tank where the health plan throws these problems at these think tanks to create solutions. I went in there, they were high school students. They were college students working on health and human service problems because they were able to think differently and look at it from a different perspective. So you're going to have to learn how to fit into the system or how to change the system. Medicaid is going to be slow, but they're going to be slow, and then they're going to be fast. Very rarely is something happening in the Medicaid program that hasn't been talked about from a payer's perspective for a long time. But you as providers get what? 30-day notice? Or, better yet, retro, back to July 1. Right? That's never happened to any of you guys, right? I used to have a policy that if it was good for the provider, I'd take it retro. If it was bad for the provider, it had to be at least 60-day notice. But 60-day notice to make technology change doesn't work, does it? So that's why I encourage you from a payer source to always stay abreast on what's happening with the health plans and the payment system. Because it's just a matter of time before you're going to have to implement it, before your technology, your EHR is going to have to get modified, before your contracting and your billing process is going to have to change. There is one thing consistent about the Medicaid program. It is going to change. It is going to change. I used to hire staff and say, if you want a program that's consistent, you're going to do the same thing every day, you don't need to come work at Medicaid. And that's probably the same thing about your agencies, right? It's probably the same thing. Budget impact is going to be one of the biggest reasons for change. It is going to be. So you cannot ignore the physical impact of behavioral health. Top 10 drug spend on the Medicaid budget in my particular state. Top 10, first 5 were behavioral health drugs. Total Medicaid spend of that $15 billion, what would you think the first #1 spender was? Most people think, oh, doctors. Doctors are way down low. Hospitals. Hospitals will run about second or third. #1 spend, behavioral health. Behavioral health. That includes IDD, substance use in my particular state. Because your spend and your services show up in the emergency room, they show up in the hospital. Substance use are going to be liver disease. Your impact is going to be across the Medicaid program. Which is why there is such a big, big push for interaction and cross-function between the medical side of the house and the behavioral side of the house. And your EHR has got to look at both. You got to be able to share data with each other. You got to be able to put real data and hit real forms in real time without having multiple thousands of clicks to share that data and to share those plans. Workloads. Workloads are going to vary. You may have a great idea on to take to your Medicaid program or to your health plan. They'd say, that's really good, but you just don't have time right now. One of the things we do as our firm is like, no problem. I know how to write that SPA. I know how to write that service definition. Let me do that for you. It's like, oh, okay. What's the next excuse? You can make a difference. You can make a difference. The word authorities means different things in the Medicaid and Medicare space, and I think you need to be, I'm not going to do a Medicaid Geek 101 lesson for you, but you do need to pay attention to that. You need to know in your state how are behavioral health services funded, because some of that is going to dictate what you can take to the health plan. If it's a straight fee for service, they are going to be very limited for adults on what they can do that's not already written in the state plan amendment. If it's 1115 waiver, you can pretty much drive a Mack truck through that. If it's a 1915B waiver, that's all, both of those are managed care. You can do a lot of different things in a B waiver. So if you are in those states that have 1115 or 1915B and they have carved in behavioral health, don't you love those words? You're carved in and carved out. You opt in and opt out. You have options to take and get funding. So it's not that managed care is bad, it's how managed care operates and how it's implemented. Because it can be your friend. It can be your friend. So don't underestimate, whatever you're doing, the need for change management. I went to one of the presentations yesterday that a colleague of mine in Mecklenburg County, Jonathan, talked about. One of the things I think most provider agencies and the state agencies, as well as other entities and vendors, I believe especially, underestimate how much time it's going to take to actually put something in place. Oh, no problem, 6 weeks. I can get that up and running in 3 months. Yeah. So I encourage you to actively think about your change management process. I always say, you think it's 6 weeks? I'm going to double that. Not always because it's not technically being done, but for staff to be able to be fluid in the actual implementation. Many times it's more than just knowing what button to push. It can take a lot of different times and a lot of different angles. And we all say, we need change, we need change. Until it's, ooh, that change impacts me. What does this mean for my job? What does this mean for the way we've always provided services? What does this mean that they want me to start asking about diabetes? I'm a behavioral health provider. Why would I need to know about BMI? I grew up as a clinician in the behavioral health space, was in Medicaid, was the deputy director over in the state division, mental health and substance use. And they wanted me, the department wanted me to go across to Medicaid. I'd always done Medicaid on the mental health side, on the division side. So I had to go to Medicaid. I didn't have to, I wanted to go to Medicaid. First thing I did was go take a medical terminology for dummies class at the community college. Because I would be talking to these thoracic surgeons and that sort of thing, and I'm thinking, I don't even know what body part you're talking about. Talk to me about mental health and substance use. I got you, man. You want to talk IDD? I got that. Ooh, that's the tongue. Okay? So I encourage you to spend time working with staff on getting them to understand the medical side of the house. Understanding why they need to know about the medical side. And it's more than just making a referral to the primary care office. It's more than just understanding the ramifications of the drugs that our individuals with behavioral health have been taking for years and the impact it's making on their chronic conditions. It's more than just understanding or appreciating why I need to think about that person who has diabetes, who also has a history of running and has been kicked out of 3 different group homes. Because the payors are going to be looking for that continuity of care and the sharing of data when those people or those individuals move. Because guess what? Our population is going to move. It happens. So what is your technology doing to support continuity of care, of services and supports as people move? So let's take a look at that data. We know data can be pretty overwhelming. We also know in order to do those continuity of care, we got to have the data to do that, and we've got to have the data to actually think about how we're going to support individuals. All of you have heard about social determinants of health, right? Okay, that either means you're asleep or you haven't. Okay, one more time. Have you heard about social determinants of health? Yes. All right. Do you care about social determinants of health? Very good. All right. I think it's as interesting that for most of our lives, we've only been dealing with the services, the typically Medicaid service. We go to the doctor's office, we go to an outpatient clinician's office, we go to a SACOT, a SAOP, residential treatment, but we haven't been taking into account those factors that contribute. The person who has diabetes that lives under the bridge, probably the last thing he or she is going to be thinking about is making sure he or she takes their insulin or they eat a well-balanced diet, right? But how do we think about those factors? And when we think about the Medicaid population, we think about our people that we're serving and these factors, social and economic factors, physical environment, health and behavior. Most of what we do, the health does not happen between the four walls of an office. It's where we live, eat, learn, work, age that really makes the difference. Does your EHR capture that data? Does your assessment capture that data? Or is your data only thinking about, or is your assessment only thinking about symptoms that we typically look at for substance use and behavioral health and the psychoed? Or am I assessing housing, transportation, toxic stress? Do I know what the person had to eat last night? So many times, it's the physical health side that is impacting the behavioral health side. Do I have a strong connection in my EHR between those two? Can I take and ingest in a meaningful way that includes risk stratification that your health plans are going to be using into the development of the person-centered plan or the treatment plan or whatever the words are that your particular agency uses? Every state is looking at these because it's one way to look at continuity, quality of life, and let's face it, control cost. Because upfront is better than afterwards. We've talked a lot, or we have over the months and the years, about whole person care. We know that people with behavioral health have 70–80% of comorbidity with a life expectancy of 20 to 25 years. That even gets worse when you start looking at it from a historically marginalized population. When you start looking at people of color, or you start looking at people with intellectual and developmental disabilities, or you start looking at areas of poverty and food deserts. Those conditions get worse. And so I question and I challenge you from a payer standpoint. I want to make sure that all of these are being looked at. I heard yesterday, I believe it was with you guys, collaborative leadership and collaborative documentation. Collaborative leadership is also going to be about who you are working with in order to do that. Some of you may offer primary care, most of you don't. But what is the relationships that you have with your community? With your community. So the community sees you as the resource, as a resource, and not somebody that they send stuff to and they don't get information back. A primary care doc does not want your 26-page person-centered plan. He or she wants a one-page document that's dashboard that bam. Because they're going to do a 15-minute. They're not going to do an hour session. Collaborative care, a lot of different codes that are in place in order for that to happen. So I challenge you to think, what is your current relationships with your community? What is your relationship with the other entities in your community? Well, no. And then we're getting into the data exchange. We've got those relationships. How am I going to share that information. You've got to make sure that whenever you're doing that information and you're sharing that information and you're getting those partnerships, you want to make sure it's somebody that aligns with your mission. And the reason why you want to make sure there's alignment is because the financial pieces have got to align. How many of you have seen this chart? Every health plan in the country is moving toward this. Every health plan. It's called the Alternative Payment Framework. Most people, providers, are in Category 1, which basically means provide a service, get paid for the service. All the payors, commercial, Medicaid, Medicare, are moving to Category 2, Category 3, and your big health systems are Category 4. So you have to be able, under Category 2, the link fee for service, and also get and report. They may offer different rates for reporting. Most health plans are not negotiating higher rates unless they are getting something out of it. And it is usually under a Category 2 or a Category 3. Some states are actually requiring, and Medicare is requiring by 2 years, 3 years, 4 years, 5 years, that 90% of their expenditures and contracting with providers will be either a Category 2 or a Category 3. So you will actually stop seeing the ability for many providers, for the majority of the services, to be in a Category 1. So you're going to want to make sure you're staying current on that. And why? Because we're getting to value-based purchasing. We're getting to measures. I've heard a lot about process and outcomes and performance measures. That's how your measures are going to be moving in those Category 2 and Category 3. I'm not going to go over this in detail, but you guys know the framework for your quality metrics, because your EHR is where that stuff's going to come from, right? That's where you're going to get it, hopefully. And so that EHR has got to ingest various pieces of data from various sources. And it's got to be ingestible and actionable. It's got to be sent, ingestible, or actionable. Again, from a payer's perspective, do I think that's easy? No. Do I think it's overnight? No. Do I think you better think about change management when doing this? Yeah. Okay? When you've done your data metrics, and I've heard a lot about measurements, have you thought about these pieces? NQF, National Quality Forum, actually lists these pieces, these factors, for any kind of data analytics. As a payer, I check for this. I look to see about validity and credibility and timeliness. I look to see whether it's distinguishable. Is it going to make a difference? Is it going to help my pain points as a payer? Is it going to keep the legislator off my back? Is it going to have me in compliance with CMS? Those are the pieces we're thinking. All right, here's a heads up, and for those of you in North Carolina, if you've heard me say this, this is a Larsonism. This is a Larsonism. CMS has a proposed rule out that goes into effect in 2025. It includes all managed care, it includes S-CHIP, it includes medical homes, and it will require the reporting of core set of children's health, behavioral health measures on the core set of adult, and the core sets of health, and your HEDIS measures. Required. You heard it here, 2 years in advance. It is a proposed rule which means it's going through public comment. The scuttlebutt is about 98% of it will move forward. So if you're not familiar with the behavioral health and substance use components of those, and the health components that go into your services, you're going to want to make sure you know what those are. Let me give you some examples of some things that also the health plans are paying for to providers. Not only is it about, do I get somebody in an appointment 72 hours within hospital discharge, or I can do a follow-up within 6 hours at an emergency room, which are some of the measures. They're also talking about Medicaid churn. Who knows what Medicaid churn is? Another geek term. I used to budget 25% Medicaid churn every year. That means people are going to lose their Medicaid. People are going to lose their Medicaid. And you know why people lose their Medicaid? They don't turn in the paperwork. So the states have been trying to do fast lane eligibility. 2 health plans, large health plans, are actually paying providers to make sure their Medicaid recipients don't lose their Medicaid eligibility. Why? Because think about the cost. If somebody comes off Medicaid, think about all the paperwork you got to do to get them back in. Think about all the paperwork that health plans got to do for a new member card and a benefit. Think about when people typically come back into the health system. When they've had a catastrophic event and they're not getting all their preventive care. So if a person loses their Medicaid eligibility, guarantee you they're going to cost you more when they come back in. Non-healthcare indicators. Got 2 health plans right now, 3 health plans that I know of, that are paying for things to help with readings. You know, one of the biggest predictors of health outcomes? 3rd grade reading level. What? 3rd grade reading level. So you got BH providers who are actually working on times with their families and their moms and their dads to actually read with their children. The Dolly Parton books, the Reach Out and Read programs with primary care. 3 health plans paying providers for reading. Health plans paying for value-added services for people on Medicaid or SCHIP to get their GED. Health plans paying for GEDs. Health plans paying for associate degrees. Because education is a way to break the poverty. How many of you have thought about you as a BH provider working on those kinds of outcomes? Staff retention rates. Got a payer who's paying X amount of dollars more per service for staff retention rates not to fall above a certain amount. Why? We all know all new staff or staff turnover causes increase in costs, greater errors in documentation, greater errors if you're in facilities and med errors, and higher costs for training. So they pay extra for retention, staff retention. Wow, that's an outcome. That's an outcome. So let's move to an area that I think most Arab people haven't thought about in the same way that I'm going to throw it out. I actually just got back about a couple of months ago from a Medicaid program, Medicaid summit on health literacy. Yes, there are Medicaid summits. And if you really want an eye-opening, enlightening conference to go to every November, there is NAMAD, the National Association of Medicaid Directors. And it is, yes, there is a club. We actually have a 12-step program for Medicaid directors. It's really quite exciting. We get t-shirts, we're alumni. But seriously, it is one of the largest. Monday's state day, all the CMSers are there, every state, all the states are there. And the next 2 days, there's probably 1,000 people that are going over what's happening in Medicaid, what the initiatives are. And this one happens to be about health literacy. Because health literacy is an area from a payer's standpoint that is going to cost quite a bit of money. And it's one of those that I think we underestimate in our EHR world, the value and the importance of health literacy. We all typically think about health literacy from the persons we serve, but not necessarily about our workforce. Not necessarily about our workforce. I was working with some case managers in a BH agency about knowing about A1C and diabetes. They had no idea what a good score should be. But yet, they were expected to be case manager for that person. Under whole person care, it's about medical, physical, social, behavioral. October is Health Literacy Month. Health literacy has been shown to prove a person with health literacy has more use of the emergency room. They have higher use of hospital stays. They have less likely to follow their treatment plan. And they have higher mortality rates. And why is that? And why is this important? Think about your operations today. Whether it's you going into your doctor's office or your behavioral health clinic, think about what you're doing and what you ask people. You register online, you find providers, you follow directions. How many times have you sat there in your doctor's office and heard something them say, and you had no idea what they were talking about? No idea. But you didn't take the ability to say, I have no idea what you're saying. Talk to me. Talk to me. This is true for your staff as well. Their reading and comprehension skills, their budget for purchasing the food, being able to have financial management, to be able to take people to actually assist them with their purchasing. Understanding the EHR directions and those task action steps that you guys are producing, that you're giving to them to read. And understanding and carrying out the plan. So I want you to think about this and rethink about this in your agency. Because as a payer, I'm really concerned about health literacy because I know it's costing me, number one, it's costing people's lives. And it's costing people to not follow their plans. But it's also costing the healthcare system. It's estimated that about $240 billion, $50 billion is related to health literacy issues, the health spend. That's a lot of bucks. That's a lot of money. Value-added services. How many of you are familiar with value-added services in managed care? Value-added services are those services that a health plan, and it's not consistent across what plans have to do, but it's not part of the Medicaid state plan, but health plans offer it for value. All health plans are looking at health literacy in some way or another for value-added services. So it is a way, from a provider's standpoint, to actually start looking at how you can support this in the bigger picture. Most individuals are not going to be willing to tell you they can't read. I sat in with an implementation of an EHR, and there was a bunch of staff in the room, direct care workers. And they were sitting there, and the vendor was sitting, he was blah, 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 and I'm looking in the audience, and I'm going, they don't have a clue. They have no idea what he is saying to them. And so we had to back up. And luckily, this vendor was not Echo, by the way. This vendor was willing to say, okay, let's stop. Let's start over. And that's where I think it's going to be important. The lowest or the highest impact is going to be older adults. Think about your workforce. Those of historically marginalized populations, those of low economic status, and medically underserved population. I don't know about you, but that sounds pretty much like a lot of the population in the behavioral health, the mental health, and substance use world. So think about your health literacy. So what does this mean? It means you as providers have got to innovate. You've got to have your data. You've got to be able to replicate your data, and you've got to be able to negotiate with your health plans. We do a lot of negotiating on behalf of providers because they're going to come in. They're going to bring in, they know how to do this, guys. They've been doing it for years. Some health plans are going to say, here's your provider contract, take it or leave it. Other providers are going to go in and say, all right, I'll take it, but I also want this based on these outcomes and these values added. So be prepared. Develop your scorecards. Develop your dashboards. Because I promise, the health plans are looking at you. They are comparing who uses the highest ER use, who does the highest medication spends, there is massive data in those health plans. They have population scientists, they're looking at population health, and making sure you understand what those pain points are. Because with it, in undermanaged care, it is beautiful on what you can do. It is beautiful. But it also requires infrastructure. And it requires internal monitoring. And so I challenge you to step up to the plate. And you have. You're here. You've got Echo. Echo, I can tell you, is one of those agencies and one of those vendors who is out there constantly trying to keep up with what's happening in the payer space. Because they're not going to become the next Blockbuster. They're going to stay up. And so with that, I'm going to stop and appreciate your listening. I didn't see anybody falling asleep in the back, and answer any questions that you may have about what's happening in the Medicaid and Medicare space from the payer standpoint. Kudos and thank you for all that you do. Questions? They're going, that was so much Medicaid geek stuff, I could care less. I'm sorry? Yes.
People ask questions. It's worth that $1.
Yeah.
That was all fantastic. If you're reading tea leaves when it comes to the ongoing growth of the momentum CCBHCs are gaining nationally,
Yep.
what does this look like for us?
So I actually had a conversation with a couple of health plans about that. I say couple because I do a lot of work with a couple. They actually are going to give priority to those those CCBHCs, making them preferred providers and actually looking at raising rates for those guys because they understand that that is something that puts you aside, that puts you above what everybody else. And by the nature of that, so I expect that to continue to grow.
And with that, we're talking about kind of individually negotiating
Yep.
value-based payment models with
Yep.
the CCBHCs.
Yep. And I think between the CCBHCs and the CINs, the clinically integrated networks, you're going to see that happen a lot in the BH space.
In Oklahoma, we have an alliance of all the CCBHCs,
Right.
and we're really looking for someone with expertise in negotiating with Medicare. We know they're coming, and so is there a clue about how to find the right consultant to come in and negotiate? I was hoping you would do that.
And Oklahoma is really interesting because Oklahoma has a Medicaid authority. It's not a state agency. And so I have some experience with them. And, you know, we talk. So, yeah, it's coming. It's
You see that as something that we should probably move forward
Yeah,
with?
yeah,
because
yeah.
Our expertise is not negotiating with NCO. Right?
Yeah, I do. I think it's, and the reason I say that is because starting small, like right now, you may want to just go ahead and pick some metrics and pick some value out and practice it. Practice it before you go and say, you know what, I'll take that up-risk contract. Because you don't, this is another Larsonism, never, ever, ever enter in an individual downsized risk where you're going to take loss on an individual. We had a provider who was like, anybody who goes into a PRTF or an inpatient after getting FCT, I'll pay the cost of that. It's like, whoa, why would you do that? You idiot. You never do an individual client. It's always across the board. But yeah, you can do a lot of that kind of stuff. Value-based purchasing is not going to go away. And behavioral health, because you know what, the spend to the Medicaid program is because of the behavioral health. The cost is not on the specialist. Primary care doesn't cost anything. It's behavioral health and the specialist that takes your Medicaid money. So, yeah.
Have you heard anything about maybe benchmarking? You talk about
Yeah.
before health, benchmarking with other agencies. Are they going to be more transparent about where you fall?
Yeah, so there is benchmarking. Of course, you got to deal with antitrust violations, so everything's going to get de-identified. And a lot of health plans are showing, you know, this the wall of shame, or just taking it and saying, here it is. If you're doing a really good internal monitoring, you're going to know where your name is up there, right? Especially if they're doing regional based. The benchmarking is also, health plans are really, really good at comparing you apples to apples. You know, like you don't want to be compared to somebody that looks differently, or they've cherry-picked all the highest functioning residents, people. So they're actually looking at benchmarking on liked agencies, but they tend to do that based on claims. They look at your algorithms and your networking and who's getting, you know, where your referrals are going to and that sort of thing. So yeah, yep. Benchmarking is a big part. Most health plans, another Larsonism, do never, ever, ever agree to 100%, ever. You won't meet 100%. Just, you know, think about what your baseline is and look at percentage of growth. And most health plans are going to be willing to do that as long as they can see, you know, 5% over benchmark or 5% over your last year's benchmark. And you think about, you know, sometimes people will think, well, yeah, 5% is not a lot. Depending on your volume and depending on what you do and what your population looks like, 2% might be really good. You know, so think about that from your benchmark standpoint. And look at, you know, statistical, gosh forbid, statistics, but it's, you know, you're not doing flat counts on some of this stuff. So, questions, other? I think we're about out of time, but I'll be around. Feel free to grab me, and it's been fun. Look forward to working with you guys and talking with you more. Thank you.